الرحمن الرحيم. برحب بحضراتكم في اليوم الثاني من ال Second Wave of the DGIS، واسمحوا لي برضو للمرة الثانية أن أنا أرحب بالفورين سبيكرز والفاكولتي المصريين في هذه الميتنج المحترمة. You are welcomed again, Professor Antonio Ciriello, Professor Andrei Chin, and Professor Doina. النهارده ان شاء الله احنا هنكمل الميتنج اللي ابتديناها امبارح، وبعد الميتنج ما تخلص فيه يعني نوع من الدسكشن لهايلايتس للامبورتنت بوينتس اللي اثيرت في او اللي هتثار في اليوم الثاني واثيرت في اليوم الاولاني. يشرفني طبعا ان انا اقدم الاستاذ دكتور صلاح، منسق والاورجنايزر of that very successful meeting to start فعاليات اليوم الثاني. بروفيسور صلاح شلباي.
Thank you, Professor Khattab, for this kind introduction, and I welcome all in this second day of the second wave of the DGIS Diabetes Guideline Implementation Summit. Today we will have a very great lectures from our foreign speakers and also from our society. Now I am honored to introduce my colleague Professor Dr. Nermin Chereva to start the first session. Dr. Nermin, please.
Bismillah ar-Rahman ar-Rahim. It's my pleasure. Fact is very interesting. The session will be a debate between two very eminent professors. Professor Andrei Chin, he's the head of the Division of Diabetes, Nutrition and Metabolic Disorders at the Academic Hospital of Liège, Belgium, and the eminent Professor Antonio Ciriello, the president of the ESD study group of diabetes and cardiovascular disease. In this joint meeting between us, the ESDL or Egyptian Society of Diabetes and Lipidology, and the group of the study group of diabetes and cardiovascular disease of the ESD. The first subject is a debate between these two eminent professors about metformin. And the question is there still a role for metformin in the management of type 2 diabetes? And I see that this question, in fact, is very weird, but there is still two opinions for answering this question. One opinion will be introduced by Professor Chin in the beginning, and the second opinion will be by Professor Ciriello. We'll start with Professor Chin. Please, Professor Chin, would you please start?
Thank you very much. So I'm ready. I'm waiting for the go. Good evening, everybody. Again, thanks for this kind invitation. So I'm very proud to participate to the debate for you, and my task will be quite difficult because my opponent is, as you mentioned before, very eminent, and I have to defend the place of metformin in diabetes management. So in fact, I have no conflict of interest directly related to metformin, but I'm participate to several cardiovascular outcome trials with GLP-1 receptor agonists and also with SGLT2 inhibitors. So I think that I also a fan for the new drugs, but nevertheless, I think that there is still a place for metformin. So what I propose to you is to go quickly through these 5 points, and why, first to start with why a debate on this topic. And in fact, this is not new, this debate. You can see that in 2017, in diabetes care, there was also a debate exactly the same. It is time to change the paradigm, no metformin, yes metformin. And you can see that the two opponents were at that time Silvio Insucci, which is very eminent professor, and it was At that time, in 2015, the leader of the ADA-EASD consensus report, and the opponent is also prestigious because it was Ralph de Fronzo. And you can see that one in Sushi defend no, we have no to change the paradigm, and metformin should remain the foundation therapy for type 2. And de Fronzo and his co-worker defend the position of GLP-1 receptor agonist, which should replace metformin in the type 2 diabetes algorithm. And the debate also continues. We have also a new reference here in 2018, exactly questioning the same topic: should metformin remain first-line therapy? So the debate is reactivated, I think, because you probably are aware of the publication of in the European Heart Journal of the new guidelines, ESC, European Society of Cardiology guidelines, in collaboration with the EASD. And in that guidelines, Antonio Cerriello was a member of this task force. They propose to dissociate the patient, drug-naive patients, and patients already on metformin. And you can see in drug-naive patient, if the patient have already atherosclerosis, cardiovascular disease, they propose to start with SGLT2 inhibitors or GLP-1 receptor monotherapy, and only add metformin if HbA1c is above the target. If the patient is already on metformin, they propose to continue metformin, and also if the patient have atherosclerotic cardiovascular disease, to add immediately SGLT2 inhibitors or GLP-1 receptor agonists, whatever the level of GLP-1 of HbA1c. In fact, when I read this paper, I was a little bit surprised, mainly by the definition of cardiovascular of patients with type 2 at high risk, not very high risk, very high risk, I can read, but high risk comprise a very broad population. Almost all population with type 2 diabetes have at least 10 years of diabetes, and also at least one other cardiovascular risk factor. And if it is the case, as you can see in these new ESC guidelines, metformin not necessarily considered as first-line drug therapy. And I was surprised because I have now to defend the place of metformin, and I'm not alone because, as you probably know, in the latest updated consensus report from the ADA-EASD published in Diabetes Care by John Booth a few months ago, metformin is confirmed as first-line drug therapy in this updated consensus report. In fact, it is a paper by de Fronzo. He compared the population, the drugs who have shown decreased CVD risk with the drug we have no effect on CVD drugs. And you can see that metformin is on the right part of the slide, and GLP-1 receptor agonist and SGLT2 inhibitors are on the left part on top of pioglitazone. But you are probably aware that all the CVUT, all the cardiovascular outcome trials performed with GLP-1 receptor agonists or SGLT2 inhibitors were performed in patients who are at risk for cardiovascular disease, but most of the patients, about 3/4 of the population, were already treated with metformin. So these new drugs were added to metformin, which was presented baseline and maintained throughout all the studies. So the first question is the metformin in the so-called average type 2 diabetic patients. It means patients without established cardiovascular disease, which is a broad population. Almost 3/4 of the population with type 2 diabetes have no established cardiovascular disease, no MI, no stroke, but of course have some cardiovascular risk factors. You are well aware that the first study who demonstrates the positive effect of metformin was the UK PDS, and the UK PDS demonstrated for the first time that a compound which is able to lower glucose is also able to reduce myocardial infarction and also to reduce all-cause mortality. Of course, this study was performed in quite small population, obese patient with newly diagnosed type 2 diabetes, but nevertheless, it demonstrates that metformin in this population can have some positive effect on cardiovascular disease. And as you know, this was confirmed 10 years later in the follow-up study of the UK PDS. 10 years afterwards, there was also a significant reduction in all-cause mortality and a significant reduction in MI 10 years after the end of the study in the patient who received metformin. In the ADOPT study, which is a study performed in newly diagnosed type 2 diabetes, also in patients without or with a low prevalence of cardiovascular disease, you are well aware also that metformin is a good compromise between rosiglitazone and glyburide. Glyburide is glibenclamide, it is a sulfonylurea with a so-called escape after a few months of treatment. But you can see that metformin is quite good, and it is a good compromise in the management of type 2 diabetes. It is cheap, we have a long experience, it is safe when we respect the contraindication, mainly severe renal disease. We will come back to renal outcome afterwards. So I think that the main question is what to do with metformin in the type 2 diabetic patients at cardiovascular risk with established cardiovascular disease, for instance. And unfortunately, we have no large outcome trials in this population. We have no comparable trial like the trials performed with GLP-1 receptor agonists or SGLT2. I must agree with that, and it is of course a lack of evidence. But nevertheless, if you try to see what happens in the all randomized clinical trials, and a meta-analysis was performed several years ago by the group of Monami and Manucci in Italy, you can see that finally they arrived to demonstrate there was no protection, no harm, but no protection. But you must know that none of these trials were performed to demonstrate such positive effect on cardiovascular disease, and mainly all these trials were performed in patients with low risk. So it's difficult to conclude about this meta-analysis. I have the opportunity already 7 years ago to publish a paper in diabetes metabolism with my co-worker Nicolas Paco, and at that time we revisited metformin because usually metformin was contraindicated in patients with stable cardiovascular or coronary artery disease, in patients after an acute coronary syndrome or MI, in patients with congestive heart failure. Usually it was in clinical practice, it was not recommended to treat this patient with metformin at that time, at least in 2013. And when I perform a systematic review on the publication in these various patients with stable coronary artery disease, post-MI and congestive heart failure, you can see that if anything, the heart rate was, the hazard ratio was below 1, except in one single study, it was below 1, and sometimes it was significant. You can see that 95% confidence interval on this column. So, if anything, at that time, when you compare the patient treated with metformin with the patient not treated with metformin, there was a positive outcome in patients receiving metformin. And this was confirmed also in a more recent publication published last year about cardiovascular mortality. You can see also that the hazard ratio was 0.81, so it was significant. You can see the confidence interval. So it means a reduction by about 20% the risk of cardiovascular mortality in patients treated with metformin compared to patients not treated with metformin. But this was performed in patients with coronary artery disease, but most of these studies were not randomized clinical trials, they were observational studies. And the same meta-analysis also compared cardiovascular events, and you can see also there was a significant reduction. In all-cause mortality, there was even a greater reduction 0.67, highly significant, as you can see, and a large number of observational studies. I know that there is a limitation for observational studies. We are exposed to potential bias, but nevertheless, the data are the data, and we have this data. And considering heart failure, this is a first publication published 7 years ago, and you can see also there was a significant reduction in patients with heart failure, very large meta-analysis. You can see 34,000 people included, and there was a 20% reduction, again significant. As this was confirmed in a more recent publication published in the Annals of Internal Medicine in 2017, you can see almost the same results, minus 22% reduction in all-cause mortality in this patient with congestive heart failure, stable, of course, stable congestive heart failure, treated by metformin compared with a patient not treated with metformin. So I think that we have no large outcome trials. Nevertheless, we have a lot of observational studies, and all the observational studies goes in the same direction. Just a few words about the renal disease. Of course, if there is a severe renal disease, there is a contraindication for the use of metformin. But as you know, probably, there was an extension of the possibility to prescribe metformin in patients with mild to moderate renal disease during the last few years. And you can see in this publication, again published 2-3 years ago, in the patient with low to moderate renal disease, you can see that the all-cause mortality is significantly reduced in patients treated with metformin compared to the patient not treated with metformin. So even in this population with renal disease, metformin may be protective. And even there was some recent paper demonstrated the so-called renoprotective effect of metformin, demonstrated in animal models, but also a few data already published in humans. So I have now to conclude, I think. So in addition to what I've already discussed, I will also point out 3 other points. First, that metformin is also exerting some positive effect beyond cardiovascular effects. As you know, there is some data suggesting an anti-cancer effect of metformin, mainly in the elderly patients, and also some data shown anti-aging properties of metformin because of this anti-inflammatory, low-grade anti-inflammatory action of metformin. Second, you know that metformin is a very old drug. We have a lot of data about safety, use in clinical practice, if we respect contraindication. And third, but I think not the least, I think that the higher cost of other drugs should be taken into account in main countries, probably also in Egypt, but also in Belgium, in France, in Europe, and probably also in the States for a lot of patients. And I think that the low cost of metformin is an argument to maintain metformin as a first-line drug in this population. And just to finish, just to demonstrate that metformin have also probably other effect, I have just published a few days ago a mini review in Diabetes Metabolism about the use of metformin in patients hospitalized with COVID-19. We have discussed a lot yesterday night about the relationship between diabetes and COVID-19, and I perform a review of the published data, and you can see that there were 4 observational studies again, comparing patients with metformin and patients without metformin, and you can see that the odds ratio are here, and on average, the odds ratio is 0.75. It means that there is a reduction of 25% of mortality. So it is a mortality here, 25% reduction of mortality in the patient receiving metformin compared to the patient not receiving metformin. Again, I know that it is observational studies. We can expect some bias, but anyway, metformin is protective in this population here. So I have the same opinion as another prestigious European diabetologist, Guntram Scherntaner. Antonio know him very well, I think, and he published in the journal where Antonio is the editor-in-chief, Diabetes Research and Clinical Practice, the right place of metformin today. And it was published a few months ago, as you can see here. And he has the same opinion as I have to defend today, that metformin, even if there is no randomized large placebo-controlled CVUT with metformin, we have sufficient data suggesting beneficial effect of metformin in this population. So my final conclusion, there is still a role of metformin. Yes, I think there is still a role of metformin. I think that the debate is reopened after the publication of the ESC guidelines. But I concluded in my paper in challenging this paper that the merit of 2019 ESC guidelines is to reactivate the discussion about important questions that concern a huge number of patients with type 2 diabetes, and thereby most physicians in charge of these patients. And I'm happy to discuss this with my friend Antonio Ceriello. I thank you for your attention.
Thank you, Dr. Chin. Thank you, Professor Chin. And now I'm welcoming Professor Antonio Ceriello to present the second part of this presentation. Dr. Antonio, would you please start?
Good evening. I think that you see my slide now. No, it's okay. You see my slide. So thank you, Andre, for the kind of introduction to my presentation, because I have to say that I am not, I will be not so tough in the sustaining no. As you see in brackets, I added maybe, not but maybe. These are my conflict of interest. You know the story, because we have to start to understand this current debate on which evidence we have at the moment in terms of what is new in diabetes therapy. Otherwise, it would be complicated to understand the scenario. You know, all the trials we got until now, and particularly the evidence in favor of SGLT2 inhibitors and GLP-1 receptor agonists, suggesting a real benefit of these two classes in preventing cardiovascular disease in diabetes. And, you know, several guidelines were following in the last years all these trials and trying to update as often as was possible. And then, as Professor Shin already introduced, we had these guidelines from the HESC, the European Society of Cardiology, in cooperation with the ESD. I was a member of this board. And you know that the problem was not, of course, when we were speaking about somebody already on metformin. There's no problem. You have somebody already on metformin. If it's at high risk and you need to add a new drug to get or not the A1C, but in our case, we suggested just in the case the A1C is not a target, just you prefer an SGLT2 on GLP-1 receptor agonist. Otherwise, if not at cardiovascular risk, you are free to choose something else. And of course, very often two drugs are not enough, and then you need the third drug, and then, okay, again, you are free to choose the best for your patients. And I have to say that at the end of the day, this position in meaning when what to do when somebody is already on metformin treatment and needs to be considered for the risk for both cardiovascular or kidney risk, complication risk, okay, it's not a doubt. Also, the recent ADASD algorithm suggests to use predominantly a GLP-1 receptor on SGLT2 agonist. The difference, of course, is what to do when somebody is just at high risk or without established cardiovascular risk. Because in the guideline, in the algorithm from ADA-ASD, it is suggested to still consider metformin on the first line. I think that it's very important to define what means a guideline and what means a position, or let's say an algorithm or consensus. Because when you build a guideline, the process is very complicated, and you need to define the classes of recommendation. Briefly, what is important when you build the guidelines is to not only to set the classes of recommendation, but also the level of evidence. Meaning that the guideline is a process which is has a very narrow, there is not so much freedom in terms of choosing particularly the level of evidence, because you see, the level of evidence is when you have data, very strong data coming from multiple randomized clinical trials of meta-analysis. The level evidence B, when you have just one trial, but you have a trial confirming, suggesting your recommendation. Level C is just the consensus or an opinion of expert. So when we compare the guidelines, the ACC-ASD guidelines to the ADA-ASD algorithm, first of all, we have to understand that we are speaking about two completely different situations. Guidelines are built according to the evidence. An algorithm or the consensus is almost at the level C, meaning for the procedure is just an expert opinion, not really substantially linked to existing evidence. And we have to take in account this because, okay, what to do when you want to, for example, to put on top of metformin something else, if you have to consider the story of a metformin. Andre, you already you showed this data from the UK PDS. No, this is very clear. This is the very small group, and it's a subgroup analysis. So cannot be considered a level A evidence at all, because and I have to say, this is in between brackets, that this data are coming in a pre-statin area. So the value is still relevant, but of course less relevant. We have evidence of an action of a drug on top of the best cardiovascular therapy, as we got in the last CVOT trials. And again, I agree that even long term, this beneficial effect of a metformin is still there after 10 years. But again, this is a very small subgroup, obese people or overweight people, and just for myocardial infarction. You already showed this, that we have a meta-analysis. We show one, I have shown another one. But when you pull the available randomized clinical trials, there is no evidence that metformin plays a key role in preventing cardiovascular disease. Of course, already you showed this meta-analysis, but you were correct, underlining that observational studies are of interest, but the value, particularly when you consider this study to build guidelines, the value is almost zero. So you cannot consider this study when you build a guideline. And it's why it's not an excuse. It's just to explain this procedure. Let us to consider that we do not have enough evidence to be still there to suggest metformin as a first-line therapy when somebody is high risk. The evidence is different, and it's certainly in favor of more of a GLP-1 or SGLT2 as a therapy in the case of people with established cardiovascular disease or very high risk for cardiovascular disease. I will go very quickly on the evidence. We have in favor SGLT2 and GLP-1 receptor agonists that they protect against cardiovascular disease. They are very helpful in, particularly SGLT2, in protecting the kidney. And also, there is no discussion about SGLT2 and heart failure. So these two classes are very, very interesting, and we have a very strong evidence in many trials going in the same direction for a positive effect in preventing cardiovascular disease, kidney disease, and heart failure for SGLT2 inhibitors. So the evidence is very strong, but also I have to say that your question, also the question of many other colleagues was okay, but in this trials we had always metformin as background therapy, so this was probably really playing a role. So this perhaps seems to be not so relevant because, for example, in the EMPA-REG outcome, it has been found that the paradox is that metformin worsened the prognosis in the people when they were using when it was used in combination with empagliflozin. So this is a paradox. It seems that on the contrary, when you have metformin on background and you add a drug which can improve the risk for cardiovascular disease, adding metformin, this beneficial effect is reduced. And this was true not only for the EMPA-REG, but also for the CANVAS. We have another paper published in Circulation. Again, for example, when metformin was added, together with the canagliflozin, the hospitalization for heart failure was higher than having only canagliflozin. Of course, as I admitted that in the case of KPDS, the story is a post-hoc analysis of a subgroup, we can say that also this is the case. So also say they have the same value, but probably the story as metformin background therapy should be revisited at least. And this is why when we built these guidelines, we were thinking and we proposed that in the case of established cardiovascular disease, or in people with very high risk for cardiovascular disease, an SGLT2 inhibitor, the GLP-1 receptor agonist, should be the first choice. And I believe that also the DGIS algorithm is going this direction, not only, but they have made a step ahead, suggesting, for example, that this kind of approach, having the metformin as background, okay, but this kind of approach should be independent from A1C value. So it's even more advanced from compared to our position. At least we say, okay, be also careful about the story of A1C, but the DGIS, the algorithm also is going ahead, say, okay, do not pay attention to A1C when somebody is at risk to use these drugs. And okay, then we go ahead. But why? So it's why, for example, we say that in this case, SGLT2 inhibitors as well GLP-1 receptor agonists should be the first line therapy. But and okay, then we have, and then you see about metformin. Do you have the evidence is 2A because there is only this UK PDS available in terms of evidence. But this is, I have to admit, please, I agree with me that this was an important step because, okay, no doubt, SGLT2 inhibitors must be the first choice. But there is a place for metformin in the case of people at risk for heart failure, because, as you already showed, there is evidence that metformin can lower the mortality in people with heart failure and diabetes. So this was also our position. But let's go ahead. I think that this is an interesting debate that, in my opinion, shortly will be not anymore appealed. I think that it's time to be more comprehensive in the management of diabetes. We have evidence. In the last years, we paid so much attention to the cardiovascular risk, and somehow we forgot that also the glycemic control is important. First, to prevent microvascular complications, but also, and we have evidence that lowering glucose also pays in terms of reducing cardiovascular risk. So probably it's time to, harmonize the so-called glucocentric and cardiocentric view in a more modern approach, which is start not with metformin alone, not SGLT2 alone, but with a combination immediately. And it's reasonable to say that if somebody is not at risk of cardiovascular, is considered not at risk for cardiovascular disease, you can have metformin as background and then something else. We have evidence from verify that the DPP4 inhibitors are good in this way. But of course, if somebody is at risk, you can have metformin as a background, but start immediately also with a combination with an GLP receptor and SGL or an SGLT2 inhibitor, because in this way you can really tackle two birds with one stone: cardiovascular risk and glucose control. So, in conclusion, metformin still has an important role in the new ESC-ESD and ADA-ESD guidelines. For the first time, metformin, at least in the ESC-ESD guidelines, is recommended in patients with heart failure, and still play a key role in the future. But starting with the combination therapy probably will enter in the usual care. Thank you very much.
Thank you very much, Dr. Serem. I'm actually very happy to hear at the end of this lecture that metformin still has a role in the guidelines, because it is a fundamental drug in our armamentarium in the treatment of diabetic patients. I wonder if there are questions from the floor. Dr. Salah, do you have any questions from the floor?
Yes, Sri.
Okay, we can shift to the second session. Thank you, Dr. Salah.
At first, let me welcome all speakers and audience, and I'd like to express my deep appreciation to both the Egyptian Society of Diabetes and Epidemiology and the Cardiovascular Working Group of European Association for the Study of Diabetes for their second wave of diabetes guidelines implementation summit. Now I have the honor to present the second speaker, Professor Doina Cartinho, a member of Cardiovascular Working Group of ESD, who work in Clinical Center of Diabetes, Nutrition and Metabolic Diseases of this University, Romania. Professor Doina will deliver a talk titled Metformin in Recent Guidelines. Professor Doina, could you please start?
Yes, thank you very much for the kind invitation. Again, I'm very happy to be in this meeting. After this wonderful debate in which I think that both speakers won, I will have my talk about metformin in guidelines. As we know, metformin was one of the earliest oral therapy introduced in type 2 diabetes in 19 1958 in United Kingdom and in 1995 for United States. Other therapies emerged at the same time, like saxagliptin and liraglutide that were approved in 2009. The question is if metformin still is in the first place or lost the crown. We know that metformin is the first choice therapy for lower glycemia and for managing diabetes type 2. But continuously emerging epidemiological data and experimental models are showing additional protective effects of metformin in cardiovascular disease. Thus, this justifying to maintain metformin as the first line of therapy. Why did this question arise? I think that it's important because it's about choosing the right diabetes medication for the right patient and for the right outcome. A great number of guidelines have been issued in recent years by the European Society of Cardiology and by the European Society for the Study of Diabetes. But the most recent, from 2019, was a collaboration between two societies having as a novelty the transition to the first line of diabetes treatment, the new therapies with cardiovascular protection. This for the first time in the history of diabetes, we have data from several cardiovascular outcome trials that indicate cardiovascular benefit from the use of these glucose-lowering drugs. The results obtained from this trial using both GLP-1 receptor analog and CGLT2 inhibitors strongly suggest that these drugs should be recommended in patients with type 2 diabetes with prevalent cardiovascular disease. But both these consensus, ADA-ASD consensus and European Society of Cardiology, they are based on the new cardiovascular outcome trials. There are 7 cardiovascular outcome trials that have examined the effect of GLP-1 receptor agonists on cardiovascular events. And we know these trials, they are now in our daily activity. It was ELIXA with lixisenatide, LEADER with liraglutide, SUSTAIN 6 with semaglutide, HARMONY with albiglutide, REWIND with dulaglutide, and PIONEER with oral semaglutide. We look at the class of recommendation, and we see that in the first place is liraglutide, as we know, showing in LEADER trial that patients with diabetes and cardiovascular risk, and there were 81% with previous cardiovascular disease, liraglutide significantly reduced the composite 3-point primary endpoint by 13%. Also in SUSTAIN 6 patient with diabetes and also high cardiovascular risk, 73 patient was with cardiovascular disease. They were randomized on semaglutide, and it was significantly reduced in the 3-point MACE by 26%. Also, REWIND trial assessed the effect of once weekly dulaglutide in subject with type 2 diabetes, and it was a hard ratio of 0.88. Looking at the CGLT2 inhibitors in this study, there are 4 important studies: EMPA-REG with empagliflozin, CANVAS with canagliflozin, DECLARE with dapagliflozin, and CREDENCE trial with canagliflozin also in renal effects. And also these studies shows important benefit. The cardiovascular benefit of CGLT2 inhibitors are mostly unrelated to an extent of glucose lowering and occur too early to be a result of weight reduction. The beneficial effects achieved in this trial are more likely the result of the reduction in heart failure associated events. Of course, we look at the chronic kidney disease because it is elevated in the patients with type 2 diabetes, and renal effects of CGLT2 were suggested in cardiovascular outcome trials of patients with type 2 diabetes and high cardiovascular risk. These positive effects on renal outcomes were demonstrated, and the results suggested that CGLT2 inhibitor may provide reduction in the risk of renal composite point. Let's start with the year 1998. It's the year of UKPDS, and the UKPDS provided evidence for the beneficial cardiovascular effects of metformin. And in the UKPDS, the metformin group had a 39 lower risk of myocardial infarction than in the conventional therapy group. It is important that this significant reduction, as Antonio showed before, in myocardial infarction was maintained over 10 years, and long-term effectiveness is, I think, very, very important. In the metformin group, significant risk reduction persisted for any diabetes-related endpoint with 21%, myocardial infarction 33%, and death for any cause of 27%. Of course, if we look at the cardiovascular risk reduction with metformin in UKPDS, there are some important numbers that show us that metformin has the first place in the therapy of type 2 diabetes because he has some very good outcomes in patients with diabetes, but also with cardiovascular risk. After 50 years in the British Journal of Diabetes and Vascular Disease appear a review which raises an important question related to the cardiovascular benefit. Is metformin a vascular drug with anti-diabetic property? Seems that we still don't know how important is to choose metformin as the first line of therapy, or it's better to use other new therapy which has important studies showing the cardiovascular protection. But at the 7th scientific session of ADA in 2010, it was shown the decrease with 24% in mortality for patients with diabetes and documented atherothrombosis. So you saw this slide. Seems that cardiovascular mortality is lower in people treated with metformin compared with patients with no metformin in treatment. And of course, it was a concern related metformin and cardiac failure. But this study shows that we don't have to be so afraid about this cardiac failure. It's a an ongoing controversy regarding the safety and effectiveness of metformin in the setting of heart failure. And of course, we cannot speak about the place of metformin in guidelines without showing his role on chronic kidney disease. Metformin has traditionally been regarded as contraindicated in the chronic kidney disease, though guidelines in recent years have been relaxed to permit therapy if the glomerular filtration rate is more than 30 milliliters per minute. As was the case with heart failure, it is time to reconsider the present contraindication for chronic kidney disease. If we look to this review, I will not insist very much on it, but all I want to say is that this review that includes 6 studies, in which metformin was used in clinic in patients with chronic kidney disease, these studies show a decrease in all cause of mortality. Then we can say that metformin is in the pole position for more than 60 years. And the question is, after 60 years, will GLP-1 receptor agonist and CGLT2 inhibitors continue to be the first recommendation for patients with diabetes and cardiovascular disease? In fact, virtually all guidelines vote the UKPDS as the justification for using metformin as first line of therapy. And the UKPDS dramatically changed the role of metformin to be the background medication on which all other pharmacotherapy was added. Let's look at the guidelines. What NICE guideline say? It offers standard release metformin as the initial drug treatment for adults with type 2 diabetes. And this is the guideline from 2019. Another guideline, in the last guideline from 2080 in Diabetes Canada, metformin is generally the first choice for people with type 2 diabetes because of its safety, low cost, and possible heart benefit. Second line glucose lowering medication was, of course, DPP-4 inhibitors, GLP-1 receptor agonist, and CGLT2 inhibitors. And this guideline is updated once in 5 years. And let's look in other parts of the world to have a real image of where is the place of metformin in these guidelines. For example, in the national clinical guidelines from management of diabetes in Kenya, these indicate the first line of therapy, metformin, but leave it to the clinician to intensify in the second line of therapy. The Committee of Clinical Practice Guidelines of Korean Diabetes Association revisited and updated the fixed clinical practice guidelines in 2019. Evidence from large clinical studies assessing cardiovascular outcomes following the use of sodium glucose cotransporter 2 inhibitors and GLP-1 receptor agonists in patients with diabetes type 2 were incorporated into the recommendation. But if we look, we see that still metformin is in the middle. And let's look a little bit on special occasion like Ramadan and in the recommendation for the management of diabetes during Ramadan, which applies the principle of ADA EASD consensus, metformin ranks first, taking into account the low risk of hypoglycemia, which is very important in this situation. In conclusion, I can say that metformin is still the first line of treatment in type 2 diabetes, and new cardiovascular outcome trial have shown cardiovascular protection. Combining metformin with new therapeutic classes as early as possible or right from the start is probably the wise decision. We are waiting to see what the future guideline will say. But I think that it's better to go together with metformin and the new therapy. Thank you very much for your attention.
Much thanks, Professor Doina, for your elegant and impressive talk. In fact, I have one very short comment and a shorter question. First, my comment, I so happy with your conclusion. This is my own opinion. Metformin is still have a role, an important role, and if not, will be the first, may just be the second drug of the glucose-lowering agent. My questions, your guidelines not touch the special groups. For example, the pregnant women, lactating women, and the obese adult or adolescent with type 1 diabetes. What your own opinion, especially there is discrepancy between the American and the European point of view of these special groups?
I think that referring to obesity, it's very clear that metformin is recommended as first line in obese patients, if I understood well the question. We have these guidelines, European guidelines and American guidelines, that goes in the same way. But now the question is what to choose first for protection of cardiovascular disease in patients with diabetes. The question is, in fact, that if one of the modern therapy studies in cardiovascular outcome trials can alone maintain the value of glycemia and on the other hand protect the patient from cardiovascular disease. So I think that this is a question, if I understand well your
I mean type 1 diabetes mellitus.
Sorry?
What I meant, a special group, this diabetic patient with type 1 diabetes, especially in particular obese adolescent with type 1 diabetes.
Of course, there are studies showing that metformin in type 1 diabetes can be effective if they have metabolic syndrome associated. And of course, if they have cardiovascular disease, some of these new medication can be associated, like CGLT2 inhibitors. But we have to, of course, to take care not to the patient not to experience ketoacidosis. So it's what all these guidelines say, that we have to put the patient in the middle of our decision. So for type 1, yes, we can associate metformin. For type 1, yes, we can associate new drugs. But we have to be careful and to look at the patient in front of us.
And
but I think Professor Donia, sorry, Dr. Atif, I think Professor Donia, this is not in the guidelines.
No,
Yes.
it's not in the guideline. That I
So
said.
I can't tell the attendants that we can use metformin in type 1, frankly. This is not in guidelines. This is something which is off-label.
Yes, it is off-label, but there are studies showing that can be effective.
It studies on a very small number of patients,
Yes, it's a very
especially regarding
small
the use of SGLT2 inhibitors. It's very small number of patients. Some studies only in 12 patients, something like this. I can't guarantee to use these drugs in type 1 diabetes because of the fear of DKA.
Yes.
Yes, of course. It is like in gestational diabetes, when it is a debate if we have to stop metformin in pregnant women or not. There are countries where metformin is used in pregnant women. But for example, in our country is not allowed to use this. So I think that this is a discussion. Of course, they don't appear in guideline, but maybe guideline will change. No?
Yes, maybe. When it changes, we can say yes.
Yes.
Thank you very much, Professor Donia. Thank you, Professor Atif.
Thank you.
And I think now we will shift to the next session. Thank you both very much.
Thank you.
Now we come to the third session of this day. We have my dear friend and colleague, one of the eminent speakers in Egypt, Professor Ibrahim Al-Brashi. He is the head of chairman of the Internal Medicine Department, Cairo University. His topic is very hot, I think, and new. He will discuss fixed combination therapy in treatment of type 2 diabetes. Professor Ibrahim, please.
Thank you, Professor Salah, for your presentation. Actually, I'm going to start my presentation by thanking Professor Donia. The previous session, she talked about two things. It's very important. First of saying that the union, so we need more than one medication for treatment of type 2 diabetes, and also guidelines should be changed or not, according to the question of Professor Dr. Atif. Actually, this is what I'm going to talk about today. Type 2 diabetes, definitely we have a clinical inertia worldwide. Actually, the sequential treatment approach is compounded by substantial inertia, indefinitely for intensification timing for the therapy. In patients, they found that in patients on only one medication, oral hypoglycemic medication, needs from 1.6 to 3 years to add another or second oral medication. And also it might need up to 7 years to add a third oral medication. And it needed even up to 7 years to start adding insulin therapy. And maybe at the end, by also extra 4 years, if you can have adding a GLP-1 receptor agonist or premixed or basal bolus insulin therapy. So we have a long time needed by the sequential treatment approach in all our guidelines for starting to have tight glycemic control. We need up to 7 years for intensification. And the American College of Clinical Endocrinology said that sequential since 2000, that sequential management of hyperglycemia is treatment to failure. And they said that a stepwise treatment approach has traditionally been used to manage patients with type 2 diabetes, but still new treatments are added only when acute symptoms become apparent. The patient starts to be acknowledged that he needs to tightly glycemic control only when have symptoms, and also even the treating physicians. And they said that since then, earlier intensification with combination therapy is recommended to achieve and to maintain targets, goals among patients with very high hemoglobin A1C level. At that time, they are talking when to start combination therapy as early as needed for this. And this was represented how the time to treatment intensification according to the baseline hemoglobin A1C, which is different from all guidelines already we are following. The patient taking one oral hypoglycemic medication adding to another oral hypoglycemic medication according to his hemoglobin A1C level. If it is the brown part and the green and the blue, if it is only more than 7 or more than 7.5 or more than 8. Each time, only the intensification may be lesser timer, although it is delayed when the hemoglobin A1C is very high. But the hemoglobin A1C just above 7, there is some form of clinical inertia, either from the doctor and even from the patient going back to the doctor that still my hemoglobin A1C is not controlled. Each time, the intensification is only timely less, a little bit less, when the patient is already in very high hemoglobin A1C. So what about the sequential versus simultaneous approach? We already all of us know that we have now 12 drug classes with different mechanism of action. All are talking about since a very long time the mechanism of action of each one of the 12 drug classes with already a lot of medication underlying each class of the medication. And the very famous Omnibus Octet presented by Professor De Fronzo that to optimize management of type 2 diabetes should be individualized, which now is very important. We have to individualize the medication needed for each patient according to different base pathophysiological defects and also associated comorbids. And we need multiple agents to target different aspects of these disorders. We have a problem in creatine, we have a problem in glucose reabsorption with the kidney, and we have the famous two problems is insulin secretory defect by the beta cell, or even insulin resistance along in the muscles and in the fat tissue. And the old guidelines only stated that the initial combination therapy recommendation when the baseline hemoglobin A1C in the American Diabetes Association since 2015, when you need to have a hemoglobin A1C more than 9. This is the initial combination therapy that is recommended. The Canadian more than 8.5. The American College of Clinical Endocrinology more aggressively, they have to start initial combination therapy only when you have above 7.5. So even the American Diabetes Association, most of us is following, it needs to be a hemoglobin A1C of our patient more than 9 to start initial combination therapy. What is the efficacy of this second line therapy after metformin? All of us are agreeing, most of us agreeing that metformin is the first line treatment. When I'm also agreeing with this. After metformin, we can add a lot of medication, including sulfonylurea or other secretagogues, the glinides. The reduction of hemoglobin A1C versus the monotherapy is extra reduction by 0.68%, but still we have extra weight gain, and the hypoglycemia relative risk is 8.9. When we add to metformin SGLT2 versus monotherapy, we have an extra reduction of 0.47%. And when we have sizolidine diused to metformin, we have an extra reduction by 0.44. And we add DP4 to metformin, extra reduction by 0.44. Most of them will have gaining weight. On the top is the secretagogue, sulfonylurea, and glinides, and also the TZDs. But we have a weight loss by 2 kilos when we add SGLT2 metformin, and neutral effect when we add DP4 inhibitor to metformin. The hypoglycemia risk, relative risk, is highest when we combine sulfonylurea and glinide plus metformin. And they stated, the American College of Clinical Endocrinology, that in 2019, combination therapy is often required and should include therapeutic agent with complementary mechanism of action, which is more logic. For patients with hemoglobin A1C more than 7.5 who are not an anti-hyperglycemic agent, metformin plus another agent is in addition to lifestyle should be initiated. And they only said that the initiation of combination therapy when hemoglobin A1C is more than 7.5. Actually, in American Diabetes Association, it is higher level when you need to add another medication. And astonishing enough, after the verified trial, which is presented in 2019, when they studied the effect of initial combination therapy on patients with hemoglobin A1C from 6.5 to 7.5, combining vildagliptin plus metformin. They found a very improvement in control of hyperglycemia and a lower rate of secondary failure of glycemic control versus monotherapy with metformin alone, or the sequential addition of metformin and vildagliptin. And they stated in the American Diabetes Association the first time to hear it in 2020 that they said, whereas previously stated there was limited evidence for initial combination therapy, this verified trial provided additional information, and they said that the initial combination of DP4 vildagliptin plus metformin had improvement even versus sequential treatment of adding DP4 inhibitor vildagliptin add on to metformin. But they said that these results are not generalized for other oral agents. So we are the first time to see that we have an evidence for initial combination therapy. What about the fixed dose combination agent for type 2 diabetes? We have a lot of medication approved worldwide, and already most of this medication is approved in our country. Combination of DP4 plus metformin, GLP-1, SGLT2 plus metformin, sulfonylurea plus metformin, TZDs or sizolidine plus metformin, and still we have this combination of SGLT2 and DP4, and already we have DP4 with TZDs and sulfonylurea with TZDs. We have a lot of combination, fixed dose combination approved in worldwide and also approved in our country. And evidence from retrospective pharmacy claims analysis suggests that adherence is improved with a fixed dose combination when you are comparing by 2-pill combination. Actually, you are reducing the number of pills, easy compliance of our patient. So it's very important, the fixed dose combination. And this use of fixed dose combination, we need to achieve control or tighten control of hemoglobin A1C is a more proactive approach, which is very important. We are not talking about sequential. Sequential, we can say it is a reactive approach. The patient already having one medication, not achieving target as a second medication. It will take time to take this decision. Adding third medication, it will extra timing. So definitely a fixed combination will be more proactively and effectively even after the improvement of the verified study. So the rationale for the use of fixed dose combination could be a complementary mode of action, definitely yes. No treatment paradigm, combination of SGLT2 and DP4 inhibitor is running now worldwide, is very important. And definitely we have a low risk of hypoglycemia and weight gain. The approved oral fixed dose combination therapy, a lot of worldwide, even approved in our country, DP4 and biguanides, it's metformin, pegretinides and metformin, SGLT2 and metformin, sulfonylurea and metformin, TZDs and metformin. This SGLT2 and DP4 still not approved in our country. DP4 and sulfonylurea added to diseases approved in our country. So we have a lot of oral fixed dose combination therapy, improving, you have a proactive approach and improving the compliance of our patients. What is the benefit of this combination therapy instead of monotherapy? When a complementary mechanism of action like DP4 are secretagogues and improving the incretin effect, and at the same time reducing the glucagon secretion by the alpha cell, plus adding a metformin, which is also one of the mechanisms is increasing GLP-1 secretion. All of them definitely improves, both of them combination working in different mode of action. So one of them is improving secretory problems in the beta cell, and the other improving the insulin resistant state. And when this combination of DP4 plus metformin, they have a meta-analysis, both DP4 and sulfonylurea can be considered as add-on therapy to metformin, but each have different effect on the risk of hypoglycemia and weight. Definitely sulfonylurea has increased more relative risk for hypoglycemia and weight gain. DP4 may be a more neutral for weight and less definitely hypoglycemia. But all of them versus monotherapy, definitely very more extra reduction of hemoglobin A1C. And one can come also combination of SGLT2 and metformin. Now we have in our country a lot of medication of this class combining metformin to SGLT2, DAPA, and CAN and empagliflozin, working different mechanism of action. We all know that SGLT2 is working on the renal absorbed glucose reabsorption, and also metformin is working in improving insulin resistance through reduction of hepatic glucose production. And this combination of SGLT2 plus metformin add on in the meta-analysis, all of them prove that more superior in reducing hemoglobin A1C. We are talking on two medication working in different mechanism of action, so we have extra benefit in reduction of hemoglobin A1C. And what about the new combination of DP4 inhibitor and SGLT2? As we said, SGLT2 inhibitors is working on the renal glucose reabsorption. DP4 is working on maintaining GLP-1 in circulation, stimulating insulin secretion, suppressing alpha cell function, and suppressing glucagon secretion. So one of the good ideas is combining DP4 inhibitor and SGLT2, either in separate pill or in one pill. And they studied the efficacy of this combination, still not available in our country, the SGLT2 inhibitor and DP4 combination. When they found the fixed dose combination of empagliflozin plus linagliptin and dapagliflozin plus saxagliptin. And they found when the treatment add on to metformin or alone, they found an extra reduction of hemoglobin A1C by even nearly 1% in the hemoglobin A1C after 24 weeks. So we have a sizable reduction when combining the empagliflozin plus linagliptin or dapagliflozin plus saxagliptin. I went that SGLT2 inhibitor and DP4 inhibitor. So this combination could be very beneficial, working in different mechanism of action. What about triple combination? Now we're talking about triple combination, backup of the metformin. We can add dapagliflozin, saxa, and even when they compare it with only metformin and DP4 inhibitor. So we are talking about combination of triple by metformin plus SGLT2 inhibitor, dapagliflozin, plus DP4 inhibitor, saxagliptin, and they compare it to metformin plus sitagliptin, which is a DP4 inhibitor. And the objective of this study was to assess the safety and long-term efficacy of early addition of DAPA plus saxa to metformin when triple therapy compared to dual therapy of DP4 inhibitor plus metformin. And they concluded that triple therapy led to significant improved glycemic control compared to conventional dual therapy. Yes, we have triple therapy now, will be more extra benefit. And they found that this combination, they have no increase in insulin glucagon added to metformin patient combination, additional reduction in glucose and hemoglobin A1C without increase in insulin that is commonly seen with saxa, and without the increase of glucagon is commonly seen in patient with DAPA. When they compare it in patient using saxagliptin is DP4 plus metformin, and more insulin secretion, and patient taking dapagliflozin or SGLT2 plus metformin, they have an increase in glucagon level. In this triple combination, they didn't find increase in insulin therapy, insulin levels, or even increase in glucagon level. So efficacy of this most fixed dose combination, all the new are very similar when you are thinking about this triple combination. We find that DAPA alone, hemoglobin A1C reduction, saxa is more or less reduction than SGLT2, the DP4 inhibitor. The combining of DAPA and saxagliptin, all of them add on to metformin, will have an extra benefit in hemoglobin A1C reduction. So, and the patient reaching the hemoglobin A1C target, which is below 7%, nearly 40% of cases. So this triple combination, we're talking about triple combination, is very important. And most of the data in this combination of DP4 plus SGLT2 inhibitor add on to metformin triple combination with an extra reduction when they compare it with dual therapy. And the same was evident also When we are talking about another SGLT2, is the empagliflozin plus another DP4 inhibitor, the linagliptin, plus metformin. This combination therapy and adding on to patient the hemoglobin A1C, more extra reduction. As you see, whatever the dose of IMPA, 10 milligrams or IMPA 25 milligrams for more an extra reduction in hemoglobin A1C. And already we have a lot of data now about the benefit of SGLT2. The DP4 are neutral or cardiovascular safe, apart from the saxagliptin in heart failure, but SGLT2 in this combination, we will benefit from the cardiovascular effect of it. And the efficacy in patient treatment naive, patient not treated before, we found that the extra combination, even in the 10 milligrams of IMPA plus 5 milligrams of linagliptin in patient who is already or with metformin, they have an extra reduction of hemoglobin A1C. Now will come the important question: is it in guidelines or not in guidelines? When we are talking about quadruple therapy, oral quadruple therapy, Professor Dr. Salah said it's not the guidelines. The American College of Clinical Endocrinology, it was talking about the combination quadruple therapy, metformin, sulfonylurea, DP4, and SGLT2. How many of our patients need this four combination of oral medication? And they, in these objectives of study, that they compare the efficacy and safety of IMPA and DAPA as component of quadruple oral hypoglycemic medication in patients poorly controlled. We are talking about hemoglobin A1C from 7.5 to 12, and they concluded that both SGLT2, either the DAPA and the IMPA, already significantly lowered hemoglobin A1C and were safe and were effective when added as a fourth oral anti-diabetic agent in patients already on triple treatment oral hypoglycemic medication, metformin, sulfonylurea, and DP4. Still, it's not in the guidelines. Most of the guidelines, when the patient is failing on triple therapy, or either to add basal insulin or GLP-1, if not using GLP-1 and stopping the DP4 inhibitor. But still, there is questions. Can we use this quadruple therapy? And I'm leaving to you, but still, this is American College of Clinical Endocrinology has this study, and they said that they have a benefit of this four combination. Now, we're talking about different aspects of combinations. Is SGLT2 and GLP-1 receptor agonist. Definitely is not in one tablet, but now after the GLP-1 receptor agonist found in oral medication, can we see it earlier, this combination in a fixed pill? But till now, the oldest data on the studies are combining this either by a plus injection and oral medication, not in one fixed pill, because one of the injectable one is oral, either the dapagliflozin plus exenatide and the canagliflozin plus liraglutide. And we are talking about definitely we have, if it's the SGLT2 inhibitor plus DP4 is more beneficial, definitely the combination of SGLT2 inhibitor and GLP-1 receptor agonist will have an extra benefit in improving. What about the injectable combination therapy? Since also in the American Diabetes Association, we found that the basal insulin and GLP-1 receptor agonists have a different mechanism of actions, and they are complementary. The basal insulin definitely will improve the peripheral glucose uptake and reduces hepatic production of glucose. This is the basal insulin we all know. What about GLP-1 receptor agonist? It also improves the glucose-dependent insulin release. All of us know that incretin is working in glucose-dependent manner, and also in decreasing the glucagon secretion and also slowing the gastric emptying. So basal insulin alone will increase the body weight and relatively high hypoglycemic risk. On the other side, the GLP-1 has reducing body weight and low hypoglycemic risk. So combining these two medications have definitely a complementary clinical effect. And is in guidelines since 2018, we are talking about initiating basal insulin, or even we can consider first the GLP-1 receptor agonist before insulin therapy. And if failed, this combination of GLP-1 receptor agonist and basal insulin might be one of the very beneficial, even before adding prandial insulin. And they said that Ideglera and Iglar Lexi, both of them we have this is two fixed dose combination of basal insulin and GLP-1 receptor agonist. So already this combination, this benefit will target both this combination, fixed ratio combination between the basal insulin and GLP-1 receptor agonist, will target both the fasting and the postprandial, will improve definitely glycemic control. And versus individual component, most of the studies, even if you use each one alone, you will have only target one of them, either the fasting or the postprandial mainly. No individual risk of hyperglycemia, as the amount of basal insulin will be reduced, weight neutral or lost because GLP-1 inducing weight reduction, neutralizing the effect of basal insulin, and slow up titration will also reduce the GIT upset of the GLP-1 receptor agonist alone, and will be more simplified regimen for the use of this combination. And they have the meta-analysis of this combination of GLP-1 receptor agonist and basal insulin found treatment that versus basal insulin or other anti-hyperglycemic improved more reduction of hemoglobin A1C by nearly more than 44%, and patient reaching a target hemoglobin A1C, which is below 7, very high, without increased relative risk of hypoglycemia, and even weight reduction. We are talking about in patient taking insulin therapy as a part of his combination, and they have a weight reduction, which is very important because most of our even on titrating insulin will have increasing in weight. And when they compare it versus basal bolus, we are talking about multiple injection of insulin, extra reduction or mean reduction of A1C by 0.1, although we are taking about 3 to 4 injection of insulin, lower relative risk of hypoglycemia, definitely because all of the other side, other arm is only insulin, and here in giving this combination versus basal bolus, well, an extra weight loss, and even they reach it up to 6 kilogram weight loss. So the benefit of this combination, adding GLP-1 to basal versus adding prandial insulin, will fewer injection versus basal bolus, weight loss, as you've seen from meta-analysis, definitely a relative risk of hypoglycemia is low, and already as because also this led from reduction of insulin doses usage when you are taking adding basal insulin or adding to it prandial insulin, basal plus or basal bolus. Definitely using GLP-1 receptor agonist will reduce the amount of insulin, so inducing weight loss and lower risk of hypoglycemia. And we have worldwide the fixed ratio combination of basal insulin and GLP-1, either using our insulin glargine plus lexenatide GLP-1 or insulin degludec plus liraglutide. These two fixed dose combination available worldwide. We are waiting to be available in the Egyptian market very soon. When a lot data, when they compare this fixed dose combination, insulin degludec and liraglutide versus patient controlled with basal insulin, you will see that hemoglobin A1C reduction will more apparently, and even patient on to oral hypoglycemic patient, and patient is insulin naive, this combination versus single each one alone, the liraglutide or the insulin degludec, add on or add on to basal insulin, the extra benefit of hemoglobin A1C reduction, most of them around more than 1.5, reaching 1.9% in reduction in hemoglobin A1C. The same is apparent when combining insulin glargine plus zeglexnide GLP-1, not patient not adequately controlled, also in oral medication. We will see that this combination versus alone adding insulin glargine or lexenatide, their extra benefit of hemoglobin A1C reduction, and the patient achieving the target are now more than the 50%. So definitely combination of this fixed dose combination versus each one alone, the GLP-1 or and plus basal insulin versus basal insulin alone or GLP-1 adding whatever used, add on to oral medication or add on to insulin therapy. And this concluded that in the recent clinical evidence support the safety and efficacy of early insulin initial combination therapy by patients with type 2 diabetes. We have a problem in clinical inertia. Starting initial combination therapy is a must. We need to see guideline changes when to start this combination therapy, and even after the verified trial, we have now a very safe procedure, we can use combination therapy very early, reaching to our target, making more proactive study. And this treating type 2 diabetic patient in primary care, what is the primary care physician are concerned. The treatment guidelines recommend sequential intensification of glucose-lowering therapy. This may involve waiting to add or replace agent until it is clear that the current treatment is not working for the patient. This is a clinical inertia. Delays occurs in glycemic control, find the treatment algorithm is too complex. So we have to help our primary care physician to have starting decision-making to when to start initial combination therapy and to have the benefit of fixed dose combination therapy. And thank you.
Thank you, Professor Ibrahim, for this elegant lecture and simple lecture, showing the importance of starting early combination therapy. Yusri, do you have any questions? Thank you again, Professor Ibrahim.
Okay, thank you, Professor Salah.
First, I want to introduce my grateful thanks for our distinguished speakers and moderators in these two waves of the DGIS for their valuable and respectable contribution for these two waves. And now it's my pleasure to introduce my friend and my professor, Professor Salah Shilbaya, one of the eminent diabetologists in Egypt and in Middle East. He is a professor of endocrinology at Ain Shams University. He will talk about the insulin therapy in diabetes and type 2 diabetes, be right from the start. Please, Professor Shilbaya.
Thank you very much, Professor Nabil, for your kind introduction. I will start my lecture, which will be about the new basal insulins analogs, or we can say second generation insulin analogs. First, we have to see if there is current unmet needs with the basal insulin therapy in general or not. So if we look here, we will see that 4 out of specialists or diabetologists, we will see that they are fear of hypoglycemia from insulin therapy, and that's why they are usually late in deciding introduction of basal insulin treatment for their patients. From patient side, we will see that 4 out of 10 patients with type 2 diabetes usually modifies their insulin dose to avoid future hypoglycemic events following a mild or a moderate episode. Once he exposed to even very mild hypoglycemic episode, he will reduce his dose of insulin, usually thinking after that attack, fearing from, again, another hypoglycemic attack. Again, we can see that 5 out of 10 patients with diabetes are not reaching HbA1c goal. 50% on insulin therapy, they are not at a goal. So definitely there is a problem. I think the problem is in the hypoglycemia, the fear of hypoglycemia, both from side of the physician and from side also of the patients. That's why they introduce the Glargine U300 basal insulin analog. If we look for the Glargine U300 regarding the pharmacodynamics and pharmacokinetics, we'll see very simply that this new insulin is Glargine, exactly like Glargine 100, but the same amount of units are only on 1/3 of the volume of the fluid. That's why when we inject it subcutaneously, you will see that the difference is in the surface area of the precipitate formed by this injected insulin. It will be very small surface area rather than a big surface area. What happened when it is small and not big like this? When it is small, when it have a small surface area, there will be more prolonged duration of action, and that's why it extends its effect for more than 24 hours. And also, if we look here, we will see that comparing the U300 versus the glargine U100, you will see that there is more flat curve in the insulin concentration within the hours, and also the glucose infusion ratio will be also more flat in comparing with glargine U100. What is the evidence for this? It is through addition studies or the addition programs. Addition program, the objective of this program was to assess the clinical efficacy and safety of glargine 300 versus glargine 100. It is a randomized study, 1-to-1, open label, parallel group, multi-center phase 3 studies. Addition program was built with similar study design across the trials to confirm the results. They enrolled patients, randomized, as I said, 1-to-1, and arm will receive glargine 300 or glargine U300 plus minus oral antidiabetics plus minus mealtime insulin versus glargine U100 plus minus oral antidiabetics plus minus mealtime insulin. It will take 6 months duration, and there is also 6 months extension period. The objective of the study is to tease the non-inferiority in controlling HbA1c at 6 months. This is the main objective. So this is the addition program. We have addition 1, which is basal bolus. This is a patient basal plus metformin bolus insulin, and this is in type 2. And we have addition 2. This is basal oral therapy, basal insulin plus oral antidiabetics, excluding sulfonylurea. And we have addition 3, the basal oral therapy, but patient was insulin naive. They didn't receive insulin before, and also excluding sulfonylurea. This is not important. This is for Japanese, and this is also for Japanese. And there is one study for type 1 diabetes. Of course, it is basal bolus, as to say basal insulin plus mealtime basal bolus insulin or short-acting insulin analog. As we say, it is a non-inferiority study in HbA1c change from baseline to month 6. This is the end point of the study. And the result was very clear. In 6 months, there is no difference between glargine 300 versus glargine 100 or Toujeo versus Lantus. And when they extend for more than 6 months again, there was more beneficial effect result, and this difference was in favor of glargine 300 with a significant difference versus the glargine 100. Now, if we look for the secondary important points, which is hypoglycemia, either nocturnal or any time of the day, we will see that in addition 1 and 2 and 3, which all on type 2 diabetic patients. If we look for the nocturnal regarding the hypoglycemic events, either less than 70 milligram per deciliter or even more, less than severe hypoglycemia, which happen at month 6, you see that it favors the use of glargine, and this is why we are going to say that glargine 300 is much, much more safe than glargine 100 regarding the nocturnal hypoglycemia. They measure it from time 12 a.m. to 6 a.m. For any time of the day, the result also is in favor of glargine 300, but not like the nocturnal hypoglycemia. If we look for the rate of hypoglycemia, this one was the incidence of the rate, but this is the rate of hypoglycemia at the month of 12 at the end after the extension period of the study. Also, it will favor the use of glargine 300 in the nocturnal hypoglycemia at the same time. And for any time of the day, it favor also, but not like for the nocturnal hypoglycemia. The event rate of hypoglycemia or severe at less than 70 milligram per deciliter or severe hypoglycemia at month 8, as we see here, at any time of the day, we have a reduction by about 14% risk reduction using this U300 versus use of glargine 100. And regarding the nocturnal, we'll see this is a very good result, 31% risk reduction was highly significant result regarding the use of U300 in safety with nocturnal hypoglycemia. Now, if we shift to another study, because we have now two basal insulin analogs in the market, which is glargine 300 and insulin degludec 100. This is a study which head-to-head randomized clinical trial in insulin-naive patient did not receive any insulin before with type 2 diabetes. It's multi-center open label, one-to-one randomized, active control, two-arm parallel group, non-inferiority also, non-inferiority study in adult participants with uncontrolled type 2 diabetes. The patient enrolled are adults with HbA1c from 7.5 to 10.5 at screening, and the body mass index range between 25 and 40 kilogram per meter square. Oral anti-diabetic use plus minus GLP-1 receptor analogs at stable doses for more or near to 3 months before the study, but no prior insulin use. They are classified to two arms. Arm will receive glargine U300 once daily, PM, and their number is the same like the other arm, which will receive insulin degludec 100 once daily, also PM, and the duration was 24 weeks. How we titrate, the objective here is to ask the patient to monitor his blood glucose by self-monitoring at the home, and the target of fasting blood glucose to be between 80 and 100 milligram per deciliter. For insulin degludec, they will start with 10 units and up titrate. For glargine U300, they will start with 0.2 units per kg and will titrate. The titration for the glargine 300 U300 is like this. If his fasting exceeding 140, he will increase the dose by 6 units. If it is between 120 to 140, by 4 units. If it is 100 to 120, by 2 units. If 80 to 100, no addition. If less than 80, he has to decrease by 2 units. As we said, the primary effective endpoint is the change of HbA1c from baseline to week 24 to see if there is superiority or non-inferiority margin between both insulins. And the safety endpoints included the incidence of confirmed hypoglycemia, confirmed by measurement of less than 70 milligram per deciliter, or severe hypoglycemia less than 54 milligram per deciliter. But we have to know that we have to record it over the full 24-week period, not nocturnal only, nocturnal or at any time. And during also weeks 0 to 12, because if we see again, if I go back to the design, we will see that this start of titration period is 12 weeks, taking 12 weeks. 12 weeks it means that it is about 3 months. Now, if we look to the result, we will see that there is no difference or there is a very good significant non-inferiority between glargine 300 and the insulin degludec, both getting the patient from this high baseline HbA1c to near normal the HbA1c 7%. So both are very good basal insulin analogs, reducing HbA1c to the target. What about the incidence of hypoglycemia between both arms? If we look, I can say it simply that there is a big difference during only the titration period, but not during the study period after that. In the titration period, which takes about 12 weeks, there is great difference between using glargine 300 versus degludec 100. As we see, the incidence is less by 26% and the rates by 23% regarding the hypoglycemia confirmed as less than 70 milligram per deciliter, and it is about minus 37% and 43% regarding the rates and incidence for blood glucose less than confirmed less than 54%. So we can say that this is only happened during the 12 weeks of titration period. After that, there is no difference in hypoglycemic rates between both insulins. So in conclusion for this study, bright study, we can say that glargine 300 and insulin degludec 100 provided similar glycemic control improvements with relatively low hypoglycemia risk. Hypoglycemia incidence and rates were comparable with both insulins during the full study period, but lower in favor of glargine 300 during the titration period 12 weeks. The choice between these longer acting basal insulins may be determined by factors such as access, cost, and other factors. If we take a sub-study from the BRIGHT trial, which showed the difference in HbA1c lowering effect and also hypoglycemia rate risk between glargine 300 and insulin degludec according to renal function. Here, this is the known patient with normal renal function. Their eGFR is more than 90. And here with mild renal impairment, their eGFR 60 to 90. And here the last group is with moderate to severe renal impairment. Their eGFR is less than 60. What they said, what they noticed from this comparison between these two groups, subgroups in the BRIGHT study, there is greater significant reduction, as we see here, in HbA1c with glargine 300 versus insulin degludec 100 in people with type 2 and has moderate and severe renal impairment, but not with patients with mild renal impairment or with patients with normal renal function. Those has non-inferiority between both insulins. The difference only noticed with the patient who has severe insulin deficiency. And if we look for the subgroups according to the age, there is no difference regarding most of the ages. Only the difference was noticed in patients above 70 years, and this difference was significant. For other ages, there is no any difference between both insulin. So finally, Mr. Chairman, we can say that Toujeo or glargine U300 has more constant and prolonged pharmacokinetics, pharmacodynamics profile, more stable and has better hypoglycemic profile and less fluctuations. Prolonged, it acts beyond 24 hours daily coverage. There is flexibility in using the injection for minus or plus 3 hours at the time of injection. Also, Glargine U300 provides effective HbA1c reduction with consistent low risk of hypoglycemia versus Glargine U100. The BRIGHT study showed Glargine 300 provided similar glycemic control improvement versus insulin degludec 100, but with significant lower hypoglycemic risk only during the titration period. BRIGHT study sub-analysis showed significant reduction of HbA1c for Glargine 300 versus IDEG 100 in special populations who has moderate to severe renal impairment and the elderly only above 70 years. Conclude the study failed to meet the primary endpoints, so secondary endpoints cannot be interpreted. Thank you very much for your attention.
Thank you, Professor Shelbaya, for this comprehensive and elegant talk as usual. And now, if there is any question, Yusri Fi. Now we end this session, and thanks again, Professor Salah Shelbaya.
Thank you.